Thanks, everyone. So we're getting into the home stretch here. We have this session on evaluation strategies, and Fran Weaver from Loyola and the VA is going to be leading it and really moderating a very participatory discussion. So I'm going to turn things over to Fran, and then we'll take probably even a little less than a 15-minute break, kind of a bathroom break. After this session and go right into the action planning and debrief session. And in full disclosure, we will end like right on time at 12:15 because I have to get to the airport. So, I am super excited for all we've done. And Fran.
So good morning, everyone. I'm going to be talking about how do we determine the success of the implementation. So we have all these great models that we're all working on. How do we evaluate whether they are successful or not? So as Elaine talked about yesterday, there are all kinds of models in implementation research. And I picked this model because it does a couple of things. One is that it's called PRISM. Russ Glasgow and colleagues developed this model, or I should say expanded something called REAIM, which most of you are familiar with, to add the contextual piece. The context in implementation is key to being successful, because if you don't have, we heard it yesterday, if you don't have leadership buy-in, if you don't have the physicians that want to do this, if patients aren't willing to do this, then you don't have a program. And it doesn't matter, if you adapted it, there's nothing to evaluate. So I'm going to focus on the bottom part of the model in terms of how we assess our effectiveness of implementation. So like I said, there are contextual factors that affect your ability to put that program together. And then at the bottom, REAIM, which is REACH, adapt, adoption, implementation, and maintenance. Those can be our evaluation elements. So first, I'd like you to think a little bit about what contextual factors can affect the success of you being able to implement your program. And, just shout it out or raise your hand or whatever. Let's start with patients. What is it about patients that can affect your ability to be successful with your model?
Let's start with an example, Fran. How far do they live? We heard different models of, are you less than 10 miles, whole state, and somewhere in between.
What about engagement? Can you engage those patients to want to participate?
Yeah, I mean, there's a couple of ways to think about it, and we've learned this over time. So, in our original program, it was living nearby. It was being more affluent, frankly, because you had resources to do things. As the model developed, our definition of success changes. So now that we add C4P, if all our patients were educated, C4P would fail, right? It would add nothing, right? So I think that these programs inherently are heterogeneous, and they need to be tailored. So, a different answer for different patients, I guess.
Yes, absolutely. So we talked a lot about patients. We've also talked a lot about providers, but why might you not have success with providers? Status quo. I'm doing what I'm supposed to be doing. I'm not going to change. Maybe they perceive this is going to be more work if they switch over to this kind of model. So those are things that you need to think about. Anything else that you may have encountered in your efforts to try and get your programs going at your sites?
Do providers want to do this work?
Exactly.
And what are their other jobs? I have a couple of different jobs, and one of them is to keep hospitalists happy. And the better I make a hospitalist job, the more someone would want to be a hospitalist, and that be a CCP, you know? So there are a lot of different sides to all
A
of
lot of
this.
cognitive dissonance there. Absolutely. And leadership. We know leadership is key. What are they thinking about? Cost. This is gonna cost me more if I go to this kind of a model. Or is it gonna save me money? What are their priorities? You know, are they building the third cancer center? That's their priority and, you know, David's little model over here, it's okay, but we're not gonna focus on it. You know, those things happen. So, you know, thinking about what, how leadership could affect your success and getting that buy-in. If you can get someone in leadership to see the value of this, it goes such a long way.
Yeah, can I just comment, and just maybe a reflection? I wonder how many of our leaders really feel like leaders. And I mean this in the following way, that like even when I talk to some of the more senior leaders, and I'll try to be intentionally non-specific, they in turn have other leaders who they report to. And they feel very evaluated and very under the gun and very much like they're short-term targets. And I think some of them are looking not to get fired. And I think it's worth thinking about, because I think it's one of the real barriers to them feeling open to things. And you know, at the same time, I think like in a place like U of C, there's a part of leaders that seek to be aspirational and you know, do really innovative stuff. But at the same time, they don't want to be fired. And I think those are some of the balances, you know, that are.
And if you could show them strong evidence that this program is helping their institution, you know, that might, you know, sway them one way or the other.
Actually, I wanted to comment on that. Keiki, I think, could be here today. But Keiki Hanami, who trained here at U of C and now is at County, you know, he and I were talking about County. And one of the things he said to me is, you know, I'm really excited this paper's going to come out soon. Having the data will really make a difference. When County does something, we either do it all the way, in which case we do it based on evidence, or we don't really do it at all. We don't do innovation. Okay? And I thought to myself, that's interesting. Because like we do things all the time at scale in this institution with very little data to support it, or data that if you scratch the surface, you would really worry wouldn't. And I'm deeply ambivalent about this.
Yeah, this is where the diffusion innovation, right? I mean, I would argue University of Chicago gets rewarded for being innovators. It attracts people who are innovators, and that's in the culture. Other institutions are, I'm not rewarded for that. I get dinged if something goes wrong. I want to make sure I am going to do evidence-based. I'm looking for the evidence. I'm open to it. So that's what's the early majority. So what you're hearing right now is we have to provide the evidence. In this case, he's saying, I need it published. There might be other types of evidence so that I can point to it and say, that gives me a reason now to adopt it in my system that is.
Well, I hope that's right, because we've been working really hard to get to the point where we could produce really solid data.
The bell curve.
Exactly. Yeah. And so it's like just thinking about like that's the context, right? The evidence is being generated in very innovative places. I just think it's so cool. You had a conference a couple of years ago, and how many people here were sparked by it? That's the early adopter people who are going, I could take a risk and try it out. And in the context, you know, so thinking about that context will evolve, and just knowing that that's just the way things diffuse will help, I think, know that, yeah, how you cross the chasm, if you will, the context changes. Does that make sense? Yeah, you're illustrating it so beautifully, David.
You had a comment?
I was just gonna say the disconnect between what is being done for the leadership, like not knowing exactly the day-to-day operations about how things function.
Mhm. Right, right. Another thing I thought of, I was thinking, about our conversation yesterday in leadership, and, I forgot who said patient stories. Would patient stories affect leadership? I know it does in the VA. So if a patient is not happy, the director hears about it and the director has to address it. But they also hear the positive stories. And that, can influence them too. So, maybe patient stories is another way to influence leadership.
Yeah, I will share, I think I said this at our conference, a year and a half ago. We have a monthly program meeting on CCP where kind of everyone comes together. And the first 10 minutes of that forever has been, sort of patient stories and thanks and all of that. And that has been, really, really important. But it's for us. And I think bringing it to more people would be valuable.
Policies, there's all kinds of policies that, that we have to, live with, deal with, and that can influence whether you're going to be able to get your program up and going and maintain it. So something to be aware of. Infrastructure, we talked about a lot about space, communication and coordination. So communicating between the different providers and how you develop some very unique solutions to communication, and the electronic medical record. So it's great that Ed, is it your site that has integrated social determinants of health into the Epic? Not you.
Well, I guess we do as an institution. I think all institutions have to do it now to a certain extent from CMS perspective, but not specific to the program. So, but I know Vanderbilt has. From there.
But that's a very useful information for a program like this, right? And to have that there and not have to keep regenerating it or flipping through the notes to find it, capturing that, can make your program more efficient. And then there's always the external factors. Maybe there's competition. Maybe there's another program out there that is looking for patients to provide comprehensive care. What about the social services that are available in the community? Where are they? What are they? How do you access them? And is distance an issue? So I heard someone in our small group yesterday say, I know the resources that are close. So 10 miles is probably about as far as I can go in terms of what resources I have. That's probably true in an urban environment. In a rural environment, my guess is you've got to expand that distance because those social services aren't going to be all close. But, up in Madison, you probably have to look beyond 10 miles for some things. So just something to keep in mind. Contextual factors have such an influence on your ability to implement the program and maintain the program. But what's difficult about contextual factors is they're not necessarily easy to quantify. And so the way you capture that information is often through qualitative methods, interviews with stakeholders, and not just one time, but repeatedly over time, observational work, going into the clinic to see what's going on, regular check-ins, kind of like, how's things going? Are you having a problem? Let's, strategize about how we might be able to address that problem. And then the participant stories, which I don't think implementation does enough of. So I really like kind of promoting that idea of the patient stories. So let's talk about reach. reach has to do with how well you're getting to the population that you want to target for CCP. So we're gonna come back to this question at the end of the discussion and really try and pinpoint some key characteristics of who our patients are for the CCP program. How do we define it? High risk, complex medical conditions. Some of you have diagnostic criteria. Some of you have utilization criteria. That's all well and good. Excuse me, but I think we have to have some unified definitions. Excuse me a minute. And then how do we get them into CCP? And you're randomizing people, right? David, how did you get your folks in?
So
Did they
when-
go with the provider or?
When we started, we recruited almost everyone in the inpatient setting. Because our criterion was, have you been hospitalized in the past year or two, basically? And that worked, very well, but at a finite pace. We then started adding other populations. One population that was a good one was people who had been hospitalized in the past 2 years, but their resident was leaving, so they needed to change primary care doctor anyway. We added a fair number of people from that. What we've been doing most recently with the greatest success is recruiting in the emergency room. And that really has worked well. And one of the particular things that we've done that has worked well is recruiting in the emergency room in the evenings and on the weekends. Because that's when people get brought to the emergency room by family members, when the family members don't have the time to deal with the stuff they need during the week. And those are the people who most need our help. And that's turned out to be one of the hardest things to staff, because most people don't want to work weekends. They don't want to work evenings. But, everyone always says, meet people where they are. Well, this is where they are. And so we've worked really hard to try to figure out how to make that work. And I'll just say it hasn't been an easy management problem. You can't hire people without saying to them, I need you to work nights and weekends, right? And so, we've had to just be really, really consistent with that messaging. And, I'll just share that, the other big thing about how you recruit people is not just where you do it and who they are, but how you talk to them. And we've engaged in very extensive training, trying to teach people about motivational interviewing, and just even getting people up to speed on the logistics. And the way I describe this, it's like almost an assembly line. There's so many steps on the process, and if you screw up any one of them, the car doesn't want to run when it comes off the assembly line. And so you got to get everything right. And I'll just share for our research coordinators who do this recruitment. And we have recruited a total in our RCTs of, I think we're around 30, it's probably about 4,000 patients. Every one of those is a battle. And it's so frustrating for them when they start, because they always fail. And then we had to deal with COVID, and we have a train the trainer model, so we lost the trainers, but I think if we end up doing a really big study together, we need to invest resources early on in training our research coordinators together, because the learning curve is brutal. But it can work. So I hope that helps.
It did.
Okay.
Are you capturing what I heard, 3 different kinds of subgroups that met the study criteria, but are really maybe qualitatively different?
Yeah, we capture all of that. We know how people get recruited and where,
You
and
say, okay, this was an evening weekend one with family, this one was this one.
yeah, mostly. Some of that is explicitly described and some of it is more implicit. So for example, when was the consent form signed kind of
Right.
stuff.
So I think as Fran is getting us to think about measures, these are possible subtypes that if the group comes together, you might want to think is categorical variable,
Sure.
because it also helps to get a sense of, well, how many of these patients are showing up in these variety. It helps you describe the sort of the generalizability.
I
of
also
your-
just want to clarify one more thing. There's one more thing about who the patients are that we haven't talked about so explicitly. Some of the programs talk about multiple hospitalizations in a year as their inclusion criteria. We started with one hospitalization in a year, and then we moved to one hospitalization in 2 years. And then we even moved down to in the emergency room at the time we're recruiting you, even if you haven't been there. And so we've moved, if anything, down the spectrum. And I would say that there are probably biggest benefits from some of the higher, although there's probably a group of people who are such high utilizers. I'm not sure they're as easy even to change, but maybe that's not true. But there's clearly a group that's very low utilizers that it's really hard to benefit, but there's a lot of people in the middle. And, I think staying towards the higher end is probably a good thing in terms of program effectiveness, but in terms of program sustainability, I think, having a little more inclusive criteria makes sense. So anyway, those are some of the choices. And then last thing I'll just say about identification. I think we saw, I guess it was Kaiser showed us yesterday, like machine learning to identify risk factors, and I do think there's a lot of opportunity in that space. We're starting to do some of that too. We're unlikely to change our inclusion criteria rapidly just because we're like nearing the end of an RCT. But when we're done with that in about 18 months, I think it's going to be a very good time for us to reset. And we're starting to do some of those analyses. And I do think, we know about 10% of Medicare patients are hospitalized in any given year. And, we don't know mostly how to predict those. And so there's presumably room to do a better job of that.
So not just patients, providers. Who are they? Are they the hospitalists, the primary care providers? What is the new model for care delivery? Is it a rounder system? Is it a provider that is a primary care provider who comes in as a consultant? I think that's the Kaiser model. So there are different ways that we can do this, as we heard yesterday. So how do you identify the providers that are going to be part of that model? Is it word of mouth? Do you already know people that are willing to join your group to do this? Any comments on how was it a group of people that like sit around in the lunchroom and say, hey, we should do this?
Well, the thing I noticed yesterday, people seem to go from their position of strength, right? So Rush had this fantastic in-home program. And when I was listening to that, I was like, what a smart, logical way to start. You already have some people who are motivated to care for highly complex individuals who are doing something, who are innovators in their own sense. Of course, at Wisconsin, it was kind of, once again, like our position of strength was our hospital medicine group. But to think about starting an outpatient clinic, we just didn't have the relationships and the buy-in to be able to do that. And Kaiser, of course, already had a kind of a complex. So I just think that notion of that ease of innovation and getting over the hump is where is your strength and identifying that early.
To that, I come back to what defines success of your program, and like for us, it's operational optimization of inpatient workflows. So the idea of trying to hire someone external to come into your group isn't as effective as hiring from within the hospitalist group who already knows the system, knows how to communicate where the patients, and it takes away from some of that inherent efficient nature of a provider, because and Francis can correct me if I'm wrong, but like initially they hired 4 BFF at the time. And I was kind of the first person I was just a hospitalist doing nocturnist and general direct care. And then a position opened up because there wasn't a good fit within the program. And then that's kind of now our standard model is like we'll recruit from within our own
Yeah.
in the larger hospitalist group because they know the system. And then it actually is successful whenever hospital medicine in general is down on FTE. Because then you can have people from our group help cover the general hospital medicine service. And it's synergistic in how effective it is.
Andrew, could you talk about how many millions of dollars of investment it took to do Rounder?
So we didn't spend any money. It was pretty, fully cost neutral.
Yeah.
But huge sort of operational lifts. So I'd say that's probably where there was at least some effort at least utilized. We didn't necessarily pay for it, but lots of operational barriers to getting something off the ground.
Yeah, and like
Ours is free.
yeah,
The only money is our research, like going into the actual research operations, but
yep.
$0 to do what we're doing right now.
Yeah, and I think I shared this like a year and a half ago when we got the CMMI grant that allowed us to start this. We had operational funds built into it to hire some FTEs and things like that. And one of the complexities of the program over time is that as the CMMI money went away, that gradually morphed into operational funds, and then they had to figure out where to sit in the organization. But we dramatically underspent the operational funds in stage 1 because we were able to do the kind of stuff we did with Rounder. And I think like I'm going to jump ahead kind of to the next section, almost not to slow this down, but just to begin to anticipate some of the content. Like what I've heard is that Rounder is feasible. And it's feasible at scale. And I see it as this bridge, that once Rounder is there, then we can add other things on top of it. And there's so much variability in everything else we're doing, but Rounder feels like if you get there, then CCP gets really cheap to add. And there's a whole variety of different ways you think about randomization and other things. But like, I think that's been key. Yeah, Joyce.
I'm just going to comment on, all of our programs are slightly different in terms of the physician role. And it's been really hard to recruit CCPs. And I think it's different because the CCP has to do and want to do both inpatient and outpatient care, which is very different than I think a lot of the other programs. And, it's inherently more of a primary care role, but we're recruiting from the section of hospital medicine, right? People aren't applying there who want to be primary care physicians. And I also want to comment that while Rounder in some ways is a natural bridge to CCP, I don't know how many of the Rounders want to be primary care physicians. And, again, there's a disconnect there that makes it work out.
Now, although I do want to point out, like we actually right now, have our full cohort of CCPs and we have a 6-person waiting, who you haven't met yet, but, I think actually could quite likely be a Rounder next year, if there's space. And really does want to do CCP. So yeah, I mean, we never we sort of advertise, but we don't really advertise. And, we get all sorts of pushback when we try to grow. Partially, it's really more than anything else, the ambulatory FTE, which is the problem. That they're in general very cautious about adding that capacity because the revenue flow in a short-term way is not as positive. But anyway, yeah.
I think I just wanna think back with what everyone said. I think the Rounder model is that pipeline for, a physician. So I started, an inpatient, and I did the hybrid, and now I'm fully outpatient. And I remember when I was a new attending, I did not want to be doing primary care. But after my progression, and I'm aging, I actually naturally liked doing this home-based primary care with the components that I had with Vanderbilt. So I had clearly in my mind, okay, if I'm gonna do primary care, it has to have all of these components. Because I think when I was a resident, that's what I saw my attendings. They didn't have all of these other components, this comprehensiveness. So you get scared of even like trying, but now with my career, I said, okay, this is, if you have all of these things, I could do primary care. So I think it's a good pipeline, and what you kind of said, eventually, I'm amazed how this group has grown, and other people would come in more and more, and you would see people starting with rounder. And then, I think I could do a little bit more primary care, 10% this year, 20%.
And what is the theme of the type of person you want for CCP? It's someone who enjoys acute care. Like usually I'm right out of residency and I'm like, I don't want to do ICU, but I want to do like acute care. But I value long-term relationships, right? I enjoy building trust. And if you can find those people who are new graduates, that's who you kind of target and say, hey, we'll get you in rounder, but there might be something in the future to do CCP.
And you want to help change systems and be an innovator. And that person is the person who's coming is like that person. Yeah.
I was gonna say, we have also one advantage, which we talked a little bit last night. We do have some internists who have that mold. Not normal here. However, we also I intentionally recruited one of our family practice docs. And so we have a family practice doc here. And so, and in our program, the number of family practitioners who want to do some more acute care, and I can actually bring them into the division of hospital medicine. And so one of our thoughts as first transition would be, well, our family practice doctor, when we have a patient who's uncovered and doesn't have a primary care doctor, we can put them into his clinic. And so that way we do, just that nice, and I'm not sure how in Chicago, Vanderbilt, I know we had some challenges in getting, family practice as part of hospital medicine, but,
we have a separate department,
yeah.
but we've been able to do some of it. And
We have a separate department as well, but when it comes to acute care.
and then Inglesis.
Yeah, exactly.
So one thing I just was really reflecting on the build from strength observation you were making. That relates to how you talk about it if you're getting others to adopt. We talk about the competing alternative. No one wants to say, I'm going to dump what I'm doing and have to adopt what you're doing. But if you have more of a yes and approach, like start with your strength and build on and scaffold to, and this is modular and it's an easy way to start. And then you're that's a different way of framing how you're thinking about it. It might also relate to how you think about because in a trial you're going to have versus usual care. And the usual care is going to have a lot of heterogeneity here if these are the sites that are participating. But, just the framing of it, right, as to you're not trying to frame one as either or, but a more yes and build here, might be something to consider as this is getting implemented more broadly, not just in an efficacy trial stage.
So the idea of if you build it, they will come. I think we have to think cautiously about that because maybe not everybody who wants to be part of this really has the right makeup to do that. So as you build your model, you need to think about who the providers are that are going to be part of it. Okay. Effectiveness. So you put this CCP program out there. We got to measure whether it's effective or not. David's doing that. Ed's going to be doing that in his project a little bit. Focus more on feasibility right now, but eventually for effectiveness. What's our expected outcomes? So we talk about continuity of care, so reducing fragmentation. How do we find that? And I'm going to come back to that at the end. But what's the best way to measure that? What variables are we talking about? Other measures of effectiveness, patient satisfaction, patient trust, are those questionnaires that we're going to ask patients to complete? What about the proportion of time or the visits that patients are seeing the same primary care provider? You're going to look for something like that as a measure of continuity. Healthcare utilization, I think you guys got that covered. Hospitalizations, hospital days, ER visits, those are all part of it. And what are the outcomes for providers? Job satisfaction, quality of life. Anything else that we should be
Other question is, doesn't Chicago sometimes recruit couples? You recruit couples like to go into your study, so like, I know patient satisfaction is interesting, but I think a lot of this does fall on like, again, looking beyond the patient, like their family and social support. And do they, like, I feel like that's another huge benefit, is like, they know that you're gonna see the same face. You're having the, like, that's why, you know, same providers having the same conversations, because it helps, that's truly also part of it, is, does their family feel comfortable when they're bringing them to your institution? And they know they're gonna be able to engage.
Yeah.
I mean, people aren't silos, right? And
Yeah,
that's
yeah.
the model we're trying to.
It also ties to the, like, what we had up here, like, who are the stakeholders and, like, you know, oftentimes, particularly for our most vulnerable, impaired patients, to the extent they have family, the family is the decision maker, and the family is one of the major beneficiaries of the improved care. So that approach is, I think, a really important one. And, you know, this is also connected to issues of cognitive impairment, which also is an area, you know, a lot of funding. And we've got some data on that already. So I think those are important elements.
Oh, excellent point about the families.
I was just gonna add, I think for this, this domain, it's important to get qualitative type variables as well. So specifically, we do a lot of interviews with patients and try to understand, well, what really do you feel makes the difference with CCP? How is care coordinated? And so trying to understand that continuity of care, I think it's a different level of richness that.
No, it's good to have mixed methods.
Can I
Oh, yeah.
just, because this is gonna come up later, and again, this is gonna bleed into the next session in a variety of ways. I just wanna mention some very practical things. In order to have adequate statistical power to look at things like hospitalization, you probably need a minimum of about 500 patients an arm, like minimum. And that's optimistic. For costs, you saw the results I presented. And, you know, I think it's at least 500 patients an arm. I think it's probably more like 1,000. And you know, you guys know how many years it's taken us to accumulate that in one spot. So if we're gonna do that, like, those are the numbers we should be thinking about in our head. Now, I'm not saying those are the final outcomes. Like, I think as you go back on this, you can ask, like, continuity of care. That's in some sense like a process of care measure. But I think we could also think about structural things, like, are we even enrolling a patient in, say, a true CCP model or in a rounder model? Right? Those, and I guess one of the questions I struggle with a little bit, and I'm eager for anyone's comments, is like, how far down that spectrum do we need to go and how quickly? You know, is it a fundable study to just try to show we can enroll people in CCP models? Because that's one of the choices that we could be making, and it may be much more practical in the short run. Won't answer, like, should the world do this, but may be paired with some papers that show, you know, some evidence that this makes a difference. Maybe it's good enough.
The measurement of health seems to be really important here. So the healthcare utilization piece is important, but if a patient with osteoarthritis is getting a knee replacement and has better functional capacity, that's a great thing. If a CCP is managing chronic kidney disease very well and getting the patient more life years before needing dialysis, that's a good thing. So measurement of health is an important piece of this, I think.
Yeah. Yesterday we heard from Kaiser about, like, you know, increased survival. I'll also share, we have very small numbers of patients in some of the subgroups, but there's a group of young men with end-stage renal disease where we see this trend towards longer survival in CCP and much higher expenditures because they're living. And, you know, that seems to me like a good thing, right? And, you know, we also see increased utilization followed by decreased utilization. So these are areas where, like, measuring health status, you know, necessary care, you know, are going to be really important. But one thing we've seen in our analysis, you know, is, like, the 2,000 patients we have in the original RCT, like, we are pushing that data as hard as you possibly can. And if we had much more, we could do much more.
I was gonna say one thing about the continuity. I would venture to guess if you asked many, many people, because this goes to, let's say, a study section who are not, most of them are not hospitalists. And one thing we probably really need to do is, and I suspect this would be true if you said, gosh, most hospital medicine, if you get admitted, you are never gonna see the same provider and you're never gonna see the same team. I actually wouldn't believe it. We actually need to publish and show how defragmented or how fragmented hospital medicine care is. There's nothing out there to show how miserable our hospital medicine system is in terms of how just putting a number that you have a 0.001% chance of ending up with the same provider when you come back the second time. So I do think we need to take it, because I think if you submitted and said, we're gonna improve continuity, they'd be like, well, isn't that already how it happens? So we need to build the burning platform.
Yeah, I will say that there is literature. There are papers out there, but they don't, hospitalists don't advertise this.
Yes.
Okay. And patients don't know.
Yeah.
Unless they've been back again and again. And I will say, when we teach motivational interviewing, that's exactly where we begin. Because every patient who has been to this hospital knows that they're going to get a different doctor every time. And not only they're going to get different doctor from week to week.
Yeah, but the funders have never been hospitalized is the problem.
Well, surprise, they're even funders are human or no humans.
I think when Fran says telling the story, right? So it's not just the story of this was great coordinated care and I love it, et cetera. It's the story of like, what was this like when you're the patient or the family member in this chaotic environment?
Yes.
And making those stories also emotionally, go with the data.
Yeah, actually, this will again connect in the next section. But one of the things I think we need to think about in the next year, I mean, when are we going to have our next meeting? Is one question. But also, what can we bring to the other meetings? So, like, should we be bringing to SHM, the Society for Hospital Medicine, sessions on discontinuity across hospitalizations and what this means to patients? And the reverse, what it means to have continuity across, hospitalizations. What should we be doing with SGIM? And what are the competencies that primary care doctors need? I mean, for those of you who don't sit in this world, hospitalists kind of grew out of general internal medicine. SGIM has always been, the Society of General Internal Medicine, always been very academic, very small. And then the Society for Hospital Medicine just like exploded in growth. And the two compete. And we sit right between them. That should be a very desirable strategic position to be, and gives us a whole set of other mechanisms to implement and disseminate.
I would go to Academy Health.
Yep, we are presenting at Academy Health. We've presented probably 6 out of the last 9 years. And including this year, we're going to do something on end of life care, and I think something else.
I got accepted.
Oh, and Stanton is going to do work on one of the med students who worked with me is going to present on preventable hospitalizations and CCP.
Kind of really tapping in as you're talking about sitting between those two worlds and I've heard this mentioned before, kind of what factors go into preventing burnout for the doctors working in this model, for what really provides meaning to the work. As I'm trying to write down a model of what CCP would look like in a very small way and thinking about names and faces and friends at Lawndale, the people who I think would be great fits, they don't, when they see patients, have this mindset of, where's the problem and I'm going to fix it. And they're like, hey, what's your problem? They have a mindset of walking alongside patients. They've lived in the community for a long time. They know these people. They're often their neighbors. And I think about my dad, who's still practicing now. And I'm like, man, he's been at the same clinic in the same town of 7,000 people 5 years before I was born. And he's still good. And it's just difficult to take him out of the fabric of the community. He knows the people, and that provides such an incredible amount of resilience to his career. And then, coming into a big urban environment, we compare our worlds and how different it is. Particularly during the COVID years, the fracture of not knowing who I was going to see next, not just on the, inpatient side where that's kind of built into it, but on the outpatient side as well. Really reaching out to people who are starting their internal medicine, family medicine training and saying, does this kind of thing wear you out? There's an alternative model that allows you to walk alongside people, not just see problems, but say, how can I use my skills to better, improve your overall quality of life, and we'll walk along this journey together. I think that's a powerful message.
Actually, raises another comment that I think I could have made in the earlier session, but didn't think to. One of the challenges we've had in studying the provider experience in CCP at U of C is the small number of people involved. Like, I have lots of observations, but like, it's probably even illegal to state them. It's be violating human subjects as far as I'm concerned, right? It's just, and just not, not the thing you do, right? But my point is, if we put together this room, all of a sudden, I bet we're in the certainly many tens of people providing this type of experience, and we've never assembled that, and that's enough data that you can actually write something about. So like, this is very low hanging and important fruit.
One more comment.
I was just gonna kind of add to what you were saying about like walking alongside the patients, but I think like throughout today's talks and just like reflecting, like there's this model really emphasizes health promotion, right? And like there's health promotion, there's sick care, and I don't think they're mutually exclusive, right? Like health promotion includes taking care of patients when they are also unwell. But this model with its multidisciplinary approach, its approach on, holistically serving a patient really is about health promotion. And like parts of it, like the patients, the providers, the setting, the institution, the structure, the healthcare system that this model does well in are all of those elements have to have some buy-in into health promotion, right? Like patients who will do well in this model at some point want to be like just beyond just like the bare survival of like getting better from whatever acute situation, but promoting like having a long-term health, like providers who will succeed in this model, also thinking about more macroscopically, like about promoting a patient's health over a long period of time. And I was thinking about like undergraduate and pre-medical requirements when we were talking about that earlier, and like how do we think about those requirements, and like not just adding liberal arts or humanities just because we know those are valuable things, but how those disciplines allow you to start thinking about health promotion, right? Like health promotion does incorporate like understanding the politics of our nation or the world. It does incorporate like anthropology. So that was just like a framework that I think kind of helped me understand. So
can I layer something on top of that? So I've been slowly watching the confirmation hearings of the current nominee to be Secretary of HHS. I watched another half hour last night. There's lots of discussion about make America healthy again, and diet and chronic disease and all that sort of stuff. And, putting aside the political context in which that's being framed and some of the things that many of us might find challenging about that view, there's something there, right? I think we all recognize that how you eat and how you live and, those things are really important. And I just want to flag, like, we've had within CCP for many years a community gardening program, nutrition programs. And I suspect that if we look around, many of us have some element, at least about diet and other things that we built in. And I just want to flag, this is an opportunity for all of us to think together about how to align, where opportunity is.
Was actually a significant part of my office visits with patients who was talking about how their lifestyle impacts their health, and what do they have available, or what can I suggest that could help them along that path. And I think that is the CCP role.
I was just gonna share, like, for my therapy training, there's this question of like, is this person in front of you a problem, a math problem or a sunset? So appreciating them, all the different, like you never look at a sunset and say like, it should be a little more purple or it should be a little more orange. I think what you're saying, and I think as we're talking about like growing the pipeline, trainees, all of us, like you can build skills to appreciate sunsets. But how we train doctors, sometimes even how we train the interdisciplinary team is problem solving oriented. And I want you to be able to solve a math problem when I'm really sick. And if I'm having a long-term relationship with you, I don't always want to be your problem. But I think you need constant support and reinforcement and like continuing education, but like continuing education, whole that in a very problem-centric sphere. I mean, we're just humans, so we're like, our minds are problem-solving machines. But I love that, like, if I look at you as a sunset, then I'm not so eager to like make you the problem and fix you. But I think we can grow that too. So how do we say that to people and kind of attract that as like, you're gonna build this along the way. We're not gonna just abandon you to like have to figure it out after all.
Thank you. Trying to move this along a little bit. Adoption is really about, did you get the program up and going? So I'm gonna jump down here. Did all the sites implement CCP? So at the beginning, I think, David, when you were giving your statistics, you said there were originally 7 sites that were going to do this and 1 site dropped out. So.
Or they hadn't yet,
Got
already,
to the point.
they were just thinking about it.
Okay.
Yeah.
So, I mean, this is kind of what we're looking at here. Were they able to actually do it? That would be adoption. And then the implementation, to what extent is the CCP site compatible or comparable to the original definition? What adaptations did each site make? We heard a lot about the variations from site to site. And why did you make them? What about the social services support? Is that going to be part of your model? How are you going to do that? And how will you measure the social service component? Is it tracking what kinds of social services they use or they get? Is it the talking to the patient about, a qualitative interview about how that was? And so did we maintain the fidelity of CCP when we start making these adaptations? At what point have we changed? We've adapted so much that it's not really CCP anymore. So something to think about with implementation. Maybe it's another program and it's a great program, but maybe it's not CCP. So just give that some thought. And then the hardest part of all, maintenance sustainability. Can you keep the program going? This is where implementation fails most often. When you're first doing implementation, you've got a lot of support. You may have a research grant to get things going. You're measuring everything, and then that support goes away, and you still have the program. Can you sustain it? Can you grow it? Or does it get abandoned because you have turnover? Some of your CCP docs leave. Can you and David, you talked about turnover earlier and what effect that might have. Maybe there's new leadership and they come in and they say, no, this program's going. So as our new leadership nationally is cutting things left and right, I mean, somebody could come in and say, no, you're not going to do this anymore. So those are all things that can affect the sustainability of your program. And so what we wanted to do in the last 15 minutes or so was pose some questions and get your thoughts about this. If we are going to do some kind of a evaluation grant or program grant through AHRQ or somewhere else, there are some key components that I think we have to agree on. The first is, who are our patients? How do we define who's a CCP patient? Do you want to write that up there? What are the key characteristics that all of the programs should incorporate in identifying these individuals? I mean, they don't have to be completely the same, but you talk about high risk and fragmented care. And how do you find these people? What do they look like? Are they the individuals that are in the ER 2 and 3 times, in the last month or two? Are they the folks that have been hospitalized repeatedly? Are they the dual users? So some of you have some very elaborate criteria in terms of diagnostic characteristics, or Kaiser has the AI to try and identify these folks. What would be a CCP patient if you had to pick from all kinds of different characteristics? Who do you think would be maybe not the ideal, but an appropriate CCP patient?
I can just share what our criteria is, and I'm not saying that this is the right way, but it comes from a function of our highest ability to impact based on the resources that we have, i.e. we can't enroll any more patients because we don't have the social worker case manager capacity. So we have to take the most high risk. So what we've done is we look at medical patients who have an RAF score based on HTC conditions greater than 2 and
Just RAF is not the Royal Air Force.
the risk adjustment factor based on your HTC conditions, and in 2025 they've expanded greatly which conditions are inclusive and how they're weighted. So greater than 2 is kind of our baseline cutoff, with 2 unplanned admissions in the last year, or greater than 3 and 1 unplanned admission. So if you think about it, that's a very high risk patient. And we take patients based on referrals or proactive screening on general hospital medicine services, where there's 15 service patient lists to look through, and this is easily extractable data from Epic.
Can I suggest a pragmatic approach to this? I think the underlying concept is models like this benefit most people who are likely to be hospitalized.
Yeah.
So that's what we're looking to predict. And there are a variety of risk selection scores, and there's a capacity. I think what I heard and what you said, I heard all of it, but to me, the most salient things are start with people who are high risk and recognize your capacity.
Yeah.
Okay. And what I think, we go down to the emergency room every couple of hours to look for patients. And we know a lot as we look at them about the things that feed into their risk score. And when we're really busy, we make sure we get to the highest risk patients, maybe a little before we get to the others, if we get to them at all. And I think that may be a strategy, that the underlying concept is people at higher risk of hospitalization. We have a variety of ways of predicting that in various places, and we try to prioritize with whatever resources we have, getting to some of the higher risk people first. And we probably have some barrier below which we don't go, but it's pretty far down there. And I don't know that we need to be much more specific than that. Does that feel reasonable to people? At least as a starting point?
Does insurance play a role at all?
That we unfortunately, we need a way that, our institutions will allow us to care for these people.
How are you starting to think about the comparator arm? Because everyone's usual care, they're not going to be taking something away from what they're doing. That wouldn't seem right. So how are you conceptualizing that maybe?
I mean, it seems like intent to treat would be the way to do, is say, hey, we're going to flag you in some sort of repository, and then after study trial, we bring you into the program.
You mean a stepwise?
I mean, so if we're going to look at the effectiveness, right? However we each enroll, it depends on, we would ideally like to enroll everyone, but if we want to study the effectiveness,
Right.
we can just track the patients who meet criteria at a certain time and then follow their
Yeah, but
trajectory.
each of your sites will have a usual care that's different.
Oh, I see. What
So-
you're saying. Yeah.
Yeah.
So I think just some thought around really documenting, as Fran is saying, what is the programs that are going on, really? Because you're not, I can't imagine anyone's gonna wanna.
I sort of said this before, but I want to sort of say it again. What I'm imagining right now is sort of two things. One, we're building out Rounder and just showing we can enroll people in it. And whether that the goal of that is to figure out if Rounder is better than a hospitalist care, like, I don't exactly know the answer of what the control looks like, but my guess it's a different hospitalist every time you come in. And, if we're going to do that, we would need to think about some sort of rigorous design, whether it's step wedge or some sort of naturalistic or intentional randomization strategy at that point. But that's one study. And then I think once you build Rounder, then you can, on top of it, do like a pretty traditional RCT for CCP, again, with some criteria. So even just the first step with Rounder is complicated, right? Because if Vanderbilt really believes Rounder is helping, they're going to want everyone.
Yeah.
Right. So, maybe part of the question is, where's that band of equipoise? Or the other strategy is, create a set of criteria that are broad enough that you can't care for all the people. And then you've got a constrained resource and you can randomize. And, either way we win. We're either going to double the size of your program, which is a win, or they're gonna, we're gonna randomize, which is a win too. The only downside is that if there isn't benefit in the lower group people, they may not be as happy. But I guess we would learn that.
Yeah, and we are randomizing. We have a constrained resource, so ours is a pragmatic, we're not going to consent. Because there are too many patients for our single team to be able to take care of. That's A. B is, there is a chance that we could screw things up. We could make our providers really unhappy, and burn them out, and they could all leave. And so there's more than just the patients in terms of outcomes for harm. So that equipoise question, this notion of we don't live in a silo, I think is important as well. And so at least our IRB kind of approved us from a pragmatic RCT standpoint, on the basis of both constrained resource, but also we are kind of screwing things up at UW.
Yeah.
This is not all perfect and roses, I'll tell you. And Sarah's doing a ton of work to smooth egos and to get people happy. And our triage doctors are having to do some extra work. And so this is actually not as easy as it sounds. So
I just out of curiosity, like, what's the hardest part?
triage.
Yeah.
Yeah.
So
Yeah.
our system is so complicated. We have 3 hospitals and your choice to go, so the triage doctors already have to think about which hospital. We have a billion services. Now you're telling me I have to worry if they're a PHP patient or not? Like, come on. So, and we have a number of triage doctors who, and it's our highest paid shift among all of our shifts, which just tells you something. Generates 0 RVUs, because it is a tough shift. And so we've just made their shift tougher.
That's been our biggest challenge as well.
Yep.
Our night triage people work from home
Yeah. We'd love
to make it more attractive.
Yeah, so.
We could probably hire our people to do triage for you for less. And they would care less too,
Yeah,
they're like, yeah, it's your patient.
And but there's just it's just like such a, Vanderbilt was complicated, like this system is like, oh my gosh, 3 hospitals and, you really are an air traffic controller. And because you're moving people across the entire city. So,
Also not an easy job.
yeah.
So what you have is you can do RCTs in an individual environment that you're tailoring, you've done it The challenge is now if you're doing a multi-site
Yeah.
study and really thinking these things through, that's all I'm trying to say, you know? Or it means you go to sites that haven't adopted yet and and you learn from what this collective learnings, what do you recommend to these others who might be sites that are interested in the majority, and you're taking your learning to help, and then you have a cleaner, comparator perhaps. Because usual care will be very uncoordinated. I mean, from what you're all saying, very uncoordinated hospitalist, continuity care, right? So thinking about it from that end.
All these systems.
So another question, we have our patients, what's our program look like? Is Rounder the foundation? Like all the programs, CCP has to have at least the Rounder component.
I guess my question is what is the most feasible model to implement when you go to your executive stakeholders? How will they allow you to implement such a study?
Well, if it
And,
costs
yeah.
no money,
Right, yeah,
that is a big help.
yeah, yeah.
And there's no funds flow issue, because I could argue that primary care generates money,
Yeah.
but it clearly requires funds flow.
Yeah.
So, my answer would be that, like, Rounder is the easiest to implement, and that it lowers the incremental cost of CCP. And I think we have sort of two studies, one about implementing Rounder and the other about adding CCP on top of Rounder.
And in many ways, CCP is sort of Rounder plus. So if a site wanted to go full bore CCP right away and had the resources to do
Absolutely
it, I don't think there'd be any problem with that per se.
Right.
But it's really hard.
I mean, I think that's a reasonable strategy.
You need to make sure you stay true to the Rounder model though, because it sounded like Kaiser.
Kaiser is the
Not
most
doing-
different of all the programs we saw.
And so the only continuity I could appreciate from theirs was that they had social workers and.
Well, they have these social visits,
Yeah.
right, by the doctors,
Right.
but it's different.
It's still.
There, it's, I think if I were to put a model of what Kaiser does, it's pediatric complex care. And if you're familiar with like the pediatric complex care model, it's usually like they're acting as consultants when patients are in the hospital, but then they're the primary care home for the patient. So they are following them, but they're not primarily responsible in the acute care setting.
Or it's like a geriatric PACE model.
Right, yeah,
Oftentimes,
yeah,
like
yeah.
when the PACE patients are hospitalized,
Yeah.
they're really communicating closely with the PACE program. And so I'll call them connectors. They're
Yeah.
really connected.
Yeah.
But they're physician connectors, which
Yeah.
is a unique thing.
Yeah.
so.
Right.
No,
So,
it's,
I agree. I think we all see that.
I do think that the Rounder model, like focusing on that, is a good first step. And it would create a lot more momentum. There are these, like, for example, I'm home-based primary care. I think that's more far out to think about. But since there's, again, the natural strength right now that you have 3 prestigious institutions that are doing a version of it, getting that word out is easier. Because again, that's, I tell my company, I said, no one trusts Cigna. But they trust Chicago, they trust Vanderbilt, they trust Wisconsin. That's your biggest strength more than anything. Once you kind of lead the pack, everyone will follow.
I also want to just note an operational implementation thing. When it turns out that we actually desperately need insurers in order to operate CCP. And the reason is that when you sign people up for a primary care doctor, you need to both have the CCP count, and you need to allow, they need to have a closed panel so they don't take anyone. So we actually have to integrate, like, and we do it right now really only with Aetna. And we want to do it with others, and for us, we need to do that. But to impanel people in a Rounder model doesn't really require anything other than organizing ourselves. So that's like yet another advantage operationally of making that the first step. And it doesn't prevent us from, in parallel, developing CCP, building it out. Honestly, we don't even need to randomize, you know, if all we're doing is building up capacity. Although I would argue that there's probably a good value in doing it.
I would, so in my mind, the next step, if you start with a rounder model alone, your next RCT is once again this question of a simpler step is to say, we're going to form really strong relation. We're going to refer all of our uncovered patients who don't have a primary care physician to these two providers who are outpatient doctors. And we're going to form this really strong kind of group. And so it's still a separate hospitals, whatever, but now we have this really kind of group meld model. Or
So you're saying CCP, but for people who don't have a primary care doctor?
so let's just say that, in a rounder model, you're taking patients who many of them have a primary care provider. But it's impossible for us to communicate with 50,000 primary care providers. It's not impossible, it's just really hard. But there is this group of patients who don't have a primary care provider. So it's that notion of you can start a CCP, right? And so you can be the primary care provider, or do we find existing people who are like, we're going to work with this small group who really care about this population or high needs, high complexity. And so rather than training new primary care providers, we're going to kind of get.
So basically what you're saying is try to get people who don't have primary care providers, a primary care provider linked to Rounder
That's
via
right. So
that.
it's that residency model that we shot before where resident A goes to clinic A, resident B. Well, right now, when we refer, we just put in, hey, we need follow-up. I have no idea who they go to, but you need to get that relationship with the organization of, we're going to refer you to these providers. They are our primary hospitalist provider care, or we're going to refer them to ourselves because we are the primary care provider.
Yeah, so one thing I just want to point out about that model.
Yeah.
I think it's super interesting. I hadn't really thought about it. One of the challenges, these are tough patients.
Yeah.
And so, if they're going into a practice, it would have to be a very well-supported practice that has a sustainable model for its,
Yeah.
and I think it's interesting.
But I would just say that in terms of, once again, it offers some really nice implementation kind of questions and challenges, and also the ability to look for efficacy in terms of, once again, you're developing data from CCP, but it's a tough model to build de novo and scratch. And so there are, how does it compare to these other models? So I'll just be thinking from other ways to do these things.
Hey, can I ask a question? Technically, we have about 2 minutes left in this session. I feel a little bit like we're succeeding tremendously, and we're already kind of a little bit into the next session. So we have a choice. Should we take let Fran finish with the third thing, take a little break and then cycle back? Or the other possibility is kind of just sort of, meld this into the next session and just keep going. Would people like a little bit of a break? And then, okay, so let's do that. Let's keep going.
I just have one more thing,
Yeah.
and I think we've already covered a lot of it, which is what are our primary outcomes? So I thought we spent a lot of time talking about, it's not just the hospitalizations, it's the quality of life, it's the health status. So we have a lot of that already. Is there anything that you think we should be capturing as part of evaluating the success of this program that we didn't talk about?
Discharge before noon.
Oh, God. Shoot down.
Care team. I've heard lots about the care team as it relates to emotional, being in a team that's supporting my likelihood of wanting to still be in this profession, resiliency you mentioned. There are, I think, measures there that maybe also to the people who pay and the health system.
Can I add one other sort of outcome? It's not like a trial outcome, but I think it's a really critical thing to be cognizant of. And it's research infrastructure. So our ability to do this is going to be dependent on our ability to capture the data we need, to analyze the data we need, to have stable teams, to have resilient groups where people can cross over and and fill in. And, you know, Nancy is like basically our community health worker while we've been struggling, you know, to get staffing resolved on that for a number of months. Like there's data pulls, there's a bunch of other stuff. So I think one thing we haven't really done as a group is talk about where we would do this, what resources are available, whether we're building from scratch or have things we can leverage, and how we make sure that you know, we're able to have this be something that isn't a net drain on our resources, but a addition to it, but an efficient complement to it. So we need to think about those things
And
too.
related to that is I would do a budget space analysis, like what does it take? I mean, some of you are saying $0, but nonetheless, documenting like what does the recipe look like? So if there's hospital or unit number 6 or 8, what you need is a space of at least this. You're going to, you know, and that's more of a budget analysis feasibility than just the cost effective. Maybe you've done that already.
You know, I also just want to point out one thing. Angie just got promoted, which is great. And one of the things on which he got promoted was he helped build up Rounder, right? And Andrew sees fewer patients in a year than he would see if he were on our clinical associate track, you know, because he's on our academic school of medicine track. And so my point is just, it's not just money, but it's a whole ecosystem of supports and recognitions that allow people to advance professionally, gain experience, have impact, publish. And so we need to think about all these things together. Now, you know, you still need a biostatistician. You still need someone to collect data. You know, I don't want to minimize money, but I don't want to limit it to
Yeah,
money.
that's the value for an academic medical campus. And
Understood.
yeah, so I mean, it's like, how do we use this also as an opportunity to get the value for it crossing over into the I mean, if really the vision is hopefully you guys are modeling the way for broader utilization of it.
Sure.
We should be thinking of it. And you can also think about creating an advisory board that might be that next round of types of units that are informing what's the information or evidence that you're generating that would help me make the case. Or whatever that might be. And so that could be a soft way, you know, of leveraging your infrastructure for, you know, gathering the data.
And just to draw one slight distinction, you know, the resources I'm talking about are resources to some extent to study this.
Right.
And there may be, you know, settings in which it's just really all about implementation without studying. That's a different story. But agreed.
Yeah.
And maybe, you know, you may decide that there's one piece of information that if all the sites could collect as a starting point, how would you do it? You know, is it something where a program is written for your EMR to extract periodically information? And then, you know, maybe you pull that all together and one site has capacity to analyze that. Or you know, there's a questionnaire that is, you know, something that you need for other reasons anyway. And you can incorporate that into the program. So some things to think about, but thank you.
Yeah. Thank you.
Appreciate the input.
This has been great. Thank you.